real life, bring it home to you and make it more real life. I have changed, this is a real patient with real results, Decipher results, medical records, etc. But I changed his name to Bob to protect his confidentiality. And so Bob is a newly diagnosed patient under the care of a multidisciplinary clinical team. So Bob here, as I think Dick and Jim was asking me about how your physicians, do you have a different physician for biopsy, do you have a different physician surgeon, etc. So Bob is part of this multidisciplinary team. So they have urologists, they have RAD-ONC, they have medical oncologists. So, you know, the urologist can sometimes, depending on your specialty, you just deal with biopsy, or the urologist can deal with biopsy and your post-op treatment. And then sometimes they even do your hormone treatment work, or perhaps you need to go to the medical oncologist. They're doing your chemotherapy, etc. So Bob is part, he's getting care at one of those institutions that provide this sort of treatment. According to Bob's medical record, he has a positive diagnosis for biopsy. He's 63 years old, has CT1C disease, and Gleason score 3+4, so a 7, but the lower Gleason score. He has 2 out of the 12 positive, 2 out of 12 of the scores were positive, and he has a PSA of 4.6. So, according to the NCCN, the guidelines that your physicians use, Bob has been characterized as having favorable intermediate risk, right? So, Bob, multidisciplinary team is an advocate for the Decipher test, so they advise him to order this test to kind of decide further treatment. Is he a good candidate for active surveillance? Is he a good candidate for immediate treatment? So the clinical value that Decipher biopsy can offer to Bob and his physicians is, should he receive active surveillance? Well, this is what I was explaining to Dick earlier, was that NCCN low risk, sometimes those 3+3 guys, they do show very high metastatic potential. So this here is what we're, on the scientist side, I won't go too detailed because it'll go right on over your head and you'll be like, why is she showing me this? But this is a heat map right here, right? The blue genes are the genes that are being turned on, overexpressed. I'm sorry, the blue genes are the genes that are turned off, underexpressed, and the red are the genes that are being overexpressed, that are on, right? So this guy was NCCN low risk, but he had very high metastatic potential. So that's why I was saying no two cancers are the same. You can have the same patient, and then this guy is off the chart from the metastatic potential. However, in Bob's case, he's NCCN, he's considered NCCN intermediate risk. So with Bob, according to those NCCN guidelines, Bob would benefit they suggest his physicians he can have pretty much any one of these treatments. Of course, you know, focal therapy, radiation therapy, RP, and then there's a bunch of different combinations, and whatever your physician may decide with your help or by himself what you need. But here, so in Bob's case, this is how we're able to help at the Decipher. When you compare Decipher to, say, NCCN low, intermediate, or high risk. So if you are NCCN low risk and you run a Decipher test and it comes back Decipher low risk, then you may benefit. We recommend, our data suggests that you may benefit from active surveillance. If you are NCCN intermediate or NCCN high risk, and you run a Decipher test and comes back low risk, then you would benefit from whatever treatment your physician decides, whether it be radiation therapy or surgery. So now if you're NCCN low risk and you come out Decipher high risk, actually if you're NCCN low risk, intermediate, or high risk, and you come out Decipher high risk, at that point, our data suggests that you would benefit from immediate or intensified treatment. So wow. Oops, sorry. Go ahead.
Okay, I'm an NCCN intermediate risk. There's no reason for me to have a Decipher test because I'm not.
Where?
You see, if Decipher comes back high risk, then in spite of your being NCCN intermediate,
right?
That's right there.
Right.
This is the NCCN. Okay.
Right. And again, remember when you talk about NCCN, they're not as accurate because that's all you can look at the Gleason score PSA, not at the molecular level. So now that Bob's radiation oncologist asked if there is Decipher data relevant to primary radiotherapy so that he can counsel Bob on this stuff, right? So remember I said on our Decipher biopsy test report, we look at 5 areas of metastasis post-surgery. But we do have a validation study we're working towards it. Of course, it's only 100 patients, so now we're doing additional studies. And we have another paper that just came out with 235 patients. But we need more patients. We won't want to put that on the Decipher test unless it's, you know, we look at it in a larger population of patients. So here, in the study, we looked at 100 men that were clinically intermediate or high-risk men. All of the men received at least 6 months of hormone therapy in addition to radiation. And the endpoint of this study was looking at their risk of metastasis. And what the data shows is that, so just need some volunteers. I'm not saying that you have what I'm about to do, but Ethan, can you stand up? Dig, like Tom, Jerry, you mind standing for me? And then can I have one more over here? Mike. Yeah. So these 5 men were part of our study. Just play with me. I'm not saying that you have any of this, but you're part of our study here, right? So you had at least 6 months of hormone therapy in addition to the radiation therapy. You had the Decipher test run. Out of you guys, 20% even having that multimodal intensified treatment, radiation and hormone therapy. One of you guys will still metastasize. So you see what I'm saying with the NCCN low risk, but it came back to Decipher high risk. That's some of the things that, right. So but 1 out of the 5 men, like any one of you would be like, I don't want to be that 1 out of the 5 men, right? So this is kind of the information, and the physician now has to decide, are you a good treatment for surgery, or will you be one of this 1 out of 5 men that, although I do all this, you're going to need something else after, perhaps longer hormone treatment, 2 years of hormone treatment. Or perhaps later on I may need to go send you to have some chemotherapy. So, thanks guys.
The low risk of 6%.
Right, but the low risk is only 6%. So if you're Decipher low risk, it only showed about 6% 5 years of metastasis.
They are 3 times higher.
Exactly.
If you are Decipher.
Right. Don't you love my mathematician? That is correct. Either fix it. Yes. Yeah. That is correct. This, you're very low, still at a only 6% versus the 1 in 5 and 20%. Right. And so, given this information, Bob is like, okay, so let's run the Decipher test. Let's see where I stand, right? And so, Bob runs the Decipher test. He comes back Decipher low risk, has a 5-year risk of metastasis if he had surgery of about 3%. And then the chance or likelihood of his upstaging of his 3+4 to say 4+3 is at about a 20% risk. And then he has about a 3-4% risk of dying from prostate cancer 10 years out, right? So what we did for Bob is that we compared Bob to about 130 patients with the exact or very, very similar clinical features as far as we look at the age, their percent positive scores, Gleason scores, etc. So based on the 130 patients with those exact scores, this is where Bob falls. So with the Decipher low risk, again, our data suggests that sometimes those guys who benefit, or those are the guys who benefit from active surveillance versus Decipher high risk guys, those guys who benefit from immediate treatment. So then Bob is like, well, now I'm wondering, how about your accuracy? So we, have explained to Bob about the area on the curve, etc. And he also wanted to know if Decipher, what's the prognosis of when you say Decipher low risk, how many of them really don't metastasize, right? That's very important because you're thinking, oh, you're predicting, but which ones really do metastasize and which ones don't? So we have about 5 multiple independent cohort studies that looks at this. And radiation therapy, and about 47% of them received salvage radiation therapy. And if we said they were Decipher low risk in this study, none of them metastasized. And this range goes, if we say they are Decipher low risk, then they have excellent prognosis, and we see that about 94 to 100% of them remain metastasis free. When you take a look at, and this is like a spectrum across the 5 studies, but when you take a look at this study on the end, in this study was validated in treatment naive men. So these men did not receive any form of treatment until they metastasized. So they didn't receive any form of radiation therapy. And so in this particular study, about 94% remained metastasis free. So what is that showing you? What does that say? That some of these men are being overtreated. Exactly. So you won't know this because if you're going off of the clinical features that are very subjective, then your physicians, Gleason score, kind of waiting for PSA rise, they're the best that they've had at the time, but they're not the best markers to measure this kind of stuff. And so Bob decides, given all that information, counseling from his physician, that he's going to go ahead and have surgery. So following up Bob's medical record post-surgery, he had a PSA negative. Decipher was great at detecting upgrading that he really had primary 4, so on biopsy he had a 3+4. Upon removal of the entire prostate, and they looked at it, it was really a 4+3. And then, so there was follow-up, because he was a patient that we kind of looked at. Remember I told you one of the patients I pulled from our prospective study, so we're trying to track this information as far as outcomes. So 3 years post his RP follow-up, currently right now he still has no presence of biochemical recurrence. And his recommendations from his physician are kind of watching if PSA rise ever occurs, which it doesn't, like in his case he was Decipher low risk, so probably pretty much good with that. But if it does, he would benefit from salvage radiation therapy. He doesn't even really need to think about any form of further treatment right now. And so, in this particular case, we had Bob and Dave that were friends. Dave's name has been changed too. So Dave was kind of like not at the same multidisciplinary institution, but Bob and Dave are friends, and Dave learns about Bob's success with using the Decipher testing and how his physician used it and utilized and is managing his care with the Decipher test. And so Dave actually just had surgery. So his medical record, he's 69 years old, a little bit older than Bob. He has Gleason 3+4. He has PT3 A to Z, so extraprostatic extensions. And after surgery, he was positive margins for testing at the apex. According to guidelines, again, that your physician are following, in this case, the American Urological Association and ASTRO guidelines, they suggest that physicians should offer adjuvant radiation therapy to patients with adverse pathological findings after surgery, and those any of the following adverse features, such as seminal vesical invasion, positive surgical margins, or extraprostatic extensions. So Dave is like, nah, I don't want to be messing with this radiation. I'm not armed with radiation therapy. So this physician is like, well, let's go ahead and get the Decipher RP test and let's see where you fall. So Dave asked his RAD-ONC, well, if I waited and just waited for a PSA, does Decipher have data showing that? Do I have to really go get radiation therapy now? What's my chances of just waiting in my metastatic risk? So this was one of our earlier studies in 2015 that compared Decipher to men that had early radiation therapy versus salvage radiation therapy. And as you can see over here on the left, shows the panel of men that came back Decipher low risk. And in those men, there was no difference 5 years out from surgery, whether they received early radiation therapy or salvage radiation therapy. So they could pretty much avoid any radiation therapy at this point. However, in the men that came back Decipher genomically high risk, there so what this was, we saw an almost 80% reduction in metastatic risk in the men that received earlier radiation therapy versus later radiation therapy if they were genomically high risk.
So this is immediately after the surgery.
Right, and adjuvant, and just to make it clearer, in this study, adjuvant therapy is defined as PSA less than 0.2 nanograms per mil. So this was good, and then Dave Ryan also shares another study that combines Decipher risk and PSA in determining the right time to have early radiation therapy. And so this is another one of our studies that looks at 422 men. This study is different from this one in that it has a control group, men that did not receive any form of radiation, and it looked at their risk of metastasis. And so in this particular study, we looked at PSA scores, a PSA defining adjuvant, early salvage, and later salvage based on the men's PSA levels. So adjuvant radiation, men with PSA less than 0.2 nanograms per mil. The early salvage radiation, men with PSA levels of 0.2 to 0.49 nanograms per mil. And then salvage radiation, men with PSA rise greater than or equal to 0.5 nanograms per mil. And this, again, your group that did not receive radiation therapy. So in the men that came back to Decipher low risk, you can see there's not much difference in risk of metastasis, 10-year risk of metastasis in men that receive early radiation therapy versus men that receive, and let me back a little bit, what they're referring to, MRD, minimal residual disease, or the early salvage radiation therapy. So there's not much difference. A slightly increased 10% risk of if they waited until the PSA rise, but look at that, like you really waited 0. Like mostly docs will hit the trigger point kind of out here, you don't really wait here. And then, however, when you look at the men that came back to Decipher high risk, you see a significant difference if you had earlier radiation therapy versus if you had early salvage or late or what's considered PSA rise 0.5, right? So if you waited here at this point for salvage therapy, if you were Decipher high risk, you're just like, if Dave was like, I don't want to have radiation therapy, what's that going to do for me, right? When you look at this risk, if at this point, if Dave waits, oh no, my point, died. One second. But in this particular point, if you did not, I think I can just do it over here. If you did not have, surgery and waited, this 38% is almost as if you did not receive any form of radiation treatment. And so here comes back to Dave, and Dave is like, well, let me run the Decipher test, let me see where I fall. Dave actually comes back to Decipher high risk, about 28% risk of metastasis. So you compare him again, this is about 127, this is I think maybe close to 200 to 300, that's actually wrong up there, 200 to 300 patients exactly with his clinical features and PT3 disease, etc. Dave comes back, Decipher high risk, and we recommend early radiation therapy in that case in which he decided he did have to have.
What's on the alternate there? What is the, what are you measuring?
Oh, Decipher risk of metastasis.
So it's 20, 40.
Right. 0, 20, 40, yes.
46% of the eyes go.
In this particular, yes, in this particular subset of patients from a commercial database. However, it goes up to about 67%.
Can you go back to that previous?
Sure. Oh, this one?
Yes.
Uh-huh.
So by early, you're talking less than 0.2.
Yes, PSA trigger less than 0.2.
So not necessarily needed to have surgery, but if your PSA rise 0.1 or 0.15.
It's not a time
That's
Right, it's more of the PSA rise, yes.
considered accurate.
Yes, okay, I think I found some batteries. Sorry, guys. Give me 1 second. I want to be able to point out the stuff too, yeah.
This is action. This is data that's would be, oh yeah,
Right.
The point is that if you have rising PSA after prostatectomy, usually your doctors rely on whatever their experience base is, and they don't know about low degree or high side effects. So, that's what the benefit of this is.
Right. Okay, guys, we're back in business. Okay. So, Dave Perkins, he came about a year after Bob's information, after speaking to Bob and talking to his own doctor. So, we've had 2-year post-RP follow-up, and so far, no presence of biopsy recurrence. So, with early radiation therapy, because he did not wait, because at that point, remember, he natored, so he did not have any presence of biochemical recurrence, PSA rise, etc. So at this point, he could avoid hormone therapy, so he just had the radiation therapy. He didn't want it, but until he saw the Decipher testing, because he was like, I'm not fond of radiation therapy. I've already removed my prostate. I'm already dealing with the healing from the continency, potency, etc. Now you want to come and tell me that you want to give me radiation therapy, and I don't have a PSA rise. What are you telling me? But after reading himself and looking at our talking to his physician, he was kind of like, I don't want to be the one that waits until my PSA rise, and then at that point now I need hormone therapy and possibly this cancer. I seem to have a very aggressive prostate cancer or prostate tumor. And now, so the earlier treatment in his case, the better.
So, in the radiation therapy, what? Do they just radiate the whole area? In this case, would you just radiate that whole area then?
So that would be
What
great.
radiation do you get
Right.
after you have the prostate?
And those are good questions because those are studies that were actually looking at different doses of radiation and as far as length of radiation treatment. Those studies, particularly right now, we can't make those decisions. It will be based on the RAD-ONC, but that's still in the pipeline to kind of figure out as far as they do try to do more zapping, particularly just that region or area versus exposing, across the entire area. So that's stuff they're looking at, but they're really, the drive home with Decipher would really be to look at, can we shorten the dosage if this person, say, is this or low risk and they still like to have radiation therapy, or, how long to have, should they be having radiation therapy. So those are the studies that are currently going on with some of the academic institutions. So we hope to have those prospective studies out and have actually outcome data versus looking at retrospective studies.
Does your risk level stay with you pre and post surgery?
That is an awesome question. So we have about 81% concordance rate between our Decipher biopsy and our Decipher post-op test. So what that means is that you do see some differential expression, and this can happen for several different reasons. One, prostate cancer has a big issue with heterogeneity, and we do not have any claims of being able to detect this. To be very honest right now, there's a lot of work that's going on across the field of prostate cancer, but no one has clearly accurately determined this heterogeneity, because you may get a tumor over here and another tumor over here that's a completely different, comprising completely different cell as far as grade of the cells, etc. So that's a problem you have to take into consideration when you're looking at Decipher biopsy versus Decipher post-op, comparing if the same guy had it done on their pre-surgery tissues, would it be the same as the post-surgery tissues? Another thing you have to look at is with the Decipher biopsy, when they take that little piece of tissue from your prostate, it quickly goes into fixative compared to when you're in surgery, taking out your prostate. Your organ is sitting there for like sometimes 2 hours to 3 hours. The physician is in surgery for like 3-4 hours. Then they have to go to pathology and they're trying to fix it. So you do have some slight variations as far as differential expression in the genes. And so those are some of the things to take into consideration. But for the most part, we do have 2 studies showing high concordance rates with the same person pre-post tissue.
Just what we should have today, when you have the Decipher test on biopsy tissue, and say they've taken 12, 24 little samples, do you combine them, or do you take 1 or 2 of those?
That is a great question, Steve. So what we take is the sample with the highest recent rate. So you may have some part of the tissue that's 3 plus 3. You may have some 3 plus 4, 4 plus 2. We want the highest rate. Our test has been validated on the highest rate. Pardon? So, right. So that's the thing. Sometimes you don't know. Oh yeah, you're just gonna take that 3 plus 4. 4 out of 3 plus 3. Right. So they're just gonna send us a 3 plus 3 tissue. But
That's concentration.
no. So we have characterized out like 1 millimeter length of the tissue, and kind of that will allow us to get enough of the RNA. I will say that with our platform, we do require a little bit more RNA on the biopsy level to be able to look at all this now for the entire genomic profile. So, any more questions? Okay. So, here's the take-home message again. This is information. I removed the doctor's name here for confidentiality. But the take-home message again is no 2 cancers are the same. And what I mean with this is that this particular doc submitted about 26 patients for Decipher testing. And about half of his patients came back Decipher low risk, and about 42% of them came back Decipher high risk. And what I'm indicating here, our test is independent of these clinical features, let me go ahead and remind you again. But I went ahead and included these little squares are the Gleason scores. Little green circles are positive surgical margins. This gray here indicates extraprostatic extensions. And this little purple square indicates seminal vesicle invasion. So if you take a look at this patient here on the left, highlighted in the yellow, has clinical features of 3 plus 4 Gleason score and positive surgical margins. This guy, with the same clinical features, 3 plus 4 positive margins, but although they have the same clinical features, they have completely different genomic profiles. This guy has almost 0% risk of metastasis, whereas this guy has almost about a 50% risk of metastasizing. So this guy here, he can pretty much do nothing after post-RB and be fine. This guy, based on our several studies, we would recommend early radiation therapy. If this guy decided, well, I don't want to, I'm going to wait for my PSA to rise and I'm going to have salvage radiation therapy, at that point, our data suggests that we need something a little more systemic. So radiation in addition to hormone therapy. And at that point, it's at your physician's discretion to decide whether you need 6 months, 2 years, 3 years hormone therapy. So I can't leave here tonight without actually just mentioning real briefly, and perhaps just like Bob and Dave, because we kind of help, like we spread the word of different tests and genomic testing, because we're always trying to advise you of these new technologies that are out there that can help you with all these different cancers in our spaces, particularly urologic cancers. So we just recently launched our new Decipher bladder cancer test, and we're looking at the muscle invasive bladder cancer. So in this particular study, we're looking at 149 genes that can help determine which men would benefit from neoadjuvant chemotherapy before removing their bladder. So with this test is just kind of subtyping men into different buckets. Is your tumor considered luminous like breast cancer? So currently right now, breast cancer has luminal, they use the terminology luminal versus basal. In the bladder field, they're even a little bit further behind than prostate cancer. in that field is they're still trying to define stuff as far as what luminal basal means and can we use it in that field, and kind of just describing how aggressive your bladder cancer is. So GenomeDx with our Decipher bladder test now kind of contributing to the bladder cancer field with our genomic testing and helping to put these men into either what's known as the luminal bucket, luminal infiltrated bucket, basal flat, and low. And the luminal men, our data shows, tend to do very well whether they receive neoadjuvant or go ahead and remove their bladder. However, so they can pretty much avoid neoadjuvant chemotherapy. However, the basal, there seem to be worse prognosis, and what we're measuring here is overall survival for 3-year overall survival. So with those basal men, those are the guys, although they do worse, with overall survival, they're the guys that benefit from early neoadjuvant chemotherapy. So this is some of the information, just real briefly, and I wouldn't go into detail, just have my slide here, so you can learn also about some of our other genomic testing we're doing. So this is they're using TURBT. So we're doing the same thing, we're able to fix that tissue and we're extracting the RNA out of it. Right. So they're able to extract the tissue and kind of look, again, pull out those expressions using the same microchip and kind of looking at the genes that are being overexpressed, underexpressed, and associated with these different molecular subtypes. And so this brings us to our summary, kind of just to summarize what we talked about this evening. I kind of explained to you our GenomeDx platform, what makes us unique and different from all the other companies that are out there. We have our disruptive and transformative platform, the GRID, which allows us to collaborate and bring to you all these new different signatures and kind of determine are you sensitive to radiation therapy, sensitive to hormone therapy, where the only current approach with our genomic tests that are completely independent from any of the existing clinical features that your urologist may be using, hence again, PSA or Gleason score. And then we have a tremendous amount of credible data, over 84 publications currently right now, and we just kind of launched this test back 2015. And then I kind of incorporated and showed you how no two cancers are the same, and how Decipher can distinguish the differences between that and help to personalize and make your treatment unique to you based on your genes that are being overexpressed or underexpressed. And then finally, again, Decipher provides access to GRID and allows us to accelerate and advance personalized treatment in prostate cancer. So before I close, I did want to mention, I didn't quite show it here because it's research purposes only, but when you order the Decipher test, your physician can check off the box that allows him to give this research only and kind of look at all your markers that are being overexpressed or underexpressed. And on this report, we can't put it under the Decipher test report because it's research only, but we're able to tell you your scores for the post radiation or you're sensitive to radiation therapy, your score for how you will respond to hormone therapy. And I will currently right now we have the chemotherapy drugs we have to look at is docetaxel, how you will respond to chemotherapy such as docetaxel. And we also just give them a profile that looks at 6 of the hallmark genes of prostate cancer, that how proliferative or how fast growing your tumor is. Is your tumor able to feed itself and with the blood vessels, grow blood vessels, we look at those markers for you. We look at your antigen markers, so if you're overexpressing antigen markers, it's, you kind of have a more aggressive form of prostate cancer, but those are actually the cancers that do well with hormone therapy, right? So we also provide that. We look at the DNA repair factor. Remember I said it. You're able to, if you go have radiation therapy and your tumor is able to repair its DNA, then you're not a good candidate for radiation therapy. So those are the information that's on this research-only profile that's free, extra added or the Decipher test. Your physician gets this information, is able to share it with you. When I say research, he can't really make clinical decisions, but it's just good to have that added information. as if your patient profile, if your patient management fails, and they have alternative strategies that they can use.
Go back to the files after the fact and get like the photos number.
That's a very good question, Steve. So currently, if you're on Medicare will go back 5 years. You can run the Decipher test and they will still pay for it at 100% if you have not received treatment as far as radiation therapy.
The test has already been done.
If it's already been, yes.
And the data beside the computer somewhere that
Yes, it's all, you're never going to delete these files. They're safe, secure in this database, de-identified. So your extraction number on your RP, on your Decipher test report, it don't matter. 10 years from now, you can go back and say, hey, I want my good report. It's stored, and your physician can get it. Yeah, so tell your, go ahead, yeah, tell your physician you like it. You may be, I don't know what part of the institution which institution you're with, but they probably already ordered it and have it on file, or you can just say, hey, I actually want it, and that's like no charge extra, they'll just get it for you.
Early on, you spoke to Polaris versus this. What about the Oncotype versus how is that different?
Right. So Oncotype as well looks at biopsy, so kind of telling you positive, your results on positive biopsy. They look at a few other pathways, I think it's about 3, so kind of look at your expression levels as far as antigen receptors. They look at, they're still, however, incorporate clinical features into what they call the GPS score, their genomic prostate score. And so they're still not completely independent of the clinical features. I think currently in the news, they actually was the first to look at all the 3 endpoints. They are currently in the news. I think they are validating now the 5-year risk of metastasis. So previously they looked at favorable, so the upstaging of your tumors, is really a 3+3 to the 4+3. So they looked at that and biochemical recurrence. Now I think they are currently just validated a few months ago to look at the 5-year risk of metastasis. But again, what makes them different from us is that they also use PCR technology. So they can't go back like with our grid because we use the microchip platform and look at the entire profile. They're just looking at the subset of genes again. And so they can't add endpoints such as radioresistance or ADT. Like, how would you do sensitive ADT therapies? So that's some of the differences with it. But again, not to discredit any genomic test, because currently we're moving forward. Any form of genomic testing you should be getting. You should not just right now be relying on clinical features. We're advancing, we're moving. So some genomic tests are more accurate than others. However, get genomic tests period because it's more personalized approach with your tumor.
What is giving you the Decipher number?
What's giving us the Decipher number?
Well, for the Gleason number, it's being humanly correct. Yeah.
Right. So how do we generate that score? So the Decipher score that I mentioned earlier was like the continuous risk score from 0 to 1. So on that microchip, you're looking at genes. So it's like, say for instance, that red and blue that I was showing you. So it's looking at. So that microchip looks like. I think to go that high. So this microchip, I was going to show you this, but actually that other one we showed you a better image here of the red and blue. Okay. Okay, so this is kind of what the microchip looks like, right? It's this big thing looking at all the markers. So the red are your genes being overexpressed, the blue being underexpressed. So what it's doing is creating these raw data expression values for each of the genes, whether it's negative numbers for not being expressed versus or elevated expression expression or numbers. And what they do is create this raw score, and I'm not the statistician on this one, but they use the algorithm that generates and converts the numbers into the decile groups from 0 to 1. And for every 0.1 or 10% increase in the Decipher score, that increases your risk
So
of
something's
metastasis.
measuring that red density of that.
Right.
Of that slide.
Correct.
Okay, you take that number and then that's transferred into a.
Right, and we're only looking, particularly they looked at the Decipher Testing looks at 22 of those biomarkers. So they run the whole chip, but out of this little chip, they've done forest algorithms or different statistics to show which of those 1.4 million markers really have showed great metastatic potential. And they look at different pathways to do this and selected those 22 genes.
Okay, so more objective than subjective.
Right. So you're looking, letting the cancer, the tumor talk to you, letting it tell you which pathway in the hallmark cancer pathways are important in deciding how aggressive your tumor is.